The supersaturated oxygen therapy is quite a new concept in the LED infarct. So today's the topic I have divided into a very basic discussion on the pathophysiology behind the supersaturated oxygen therapy. What is the mechanism of action of the supersaturated oxygen therapy and the impact of the supersaturated oxygen therapy in the STEMI and the delivery of the supersaturated oxygen therapy and the some of the trials are there which are supporting the supersaturated oxygen therapy. So coming to the very beginning, the pathophysiology, the basic thing is there are some patchy regions of residual microvascular ischemia which are remain in the reperfused coronary bed when opening an epicardial coronary artery even after establishing the patency. So they are the mechanisms where the reperfusion, which is typically heterogeneous within the microvasculature, resulting in the patchy areas of residual ischemia or hypoxemia in the ischemic risk zone. There can be some microvascular damage, including the endothelial cell swelling and the microembolies which are present to contribute to this. And there are some also focal areas of incomplete reperfusion caused by the microvascular abnormalities in the regions where the microvascular cells are still viable. Ongoing ischemia or the hypoxemia can also lead to the extension of this myocardial cell death and the increased infarct size. And a cycle of hypoxia-driven vascular endothelial growth factor expression also causes the increased endothelial cell permeability and leading to an myocardial edema, and all of this contribute to the progressive infarct expression and also the residual microvascular ischemia. So that is the basic of the reperfusion injury post-MI, starting from the very beginning, from the reversible phase, there is the myocardial stanning or the reperfusion arrhythmias, and then the irreversible phase, the coronary no reflow or the microvascular obstruction, and ultimately leading to the lethal myocardial reperfusion injuries. So the mechanism of the microvascular obstruction was the very beginning at the capillary lumen level, the endothelial blebs, then the regional endothelial swelling, and then the endothelial gap, and the extravascular RBCs accumulation, and there is the fibrin, and there is also an Solon microcyte which is compressing the at the microvascular level, and the microemboli formations. So all are leading to the microvascular obstruction. And also the supersaturated oxygen therapy, now how it is acting on this microvascular obstruction. So after the primary stenting on the anterior STEMI, the LED STEMI, it restores the blood flow to improve the outcomes, but damage in the microvasculature can persist due to the reactionary changes which occurs at the cellular level. Now the supersaturated oxygen therapy, basically it is an hyperoxemic level of this dissolved oxygen at a very high pressure, 7 to 10 kilopascal. Normally it is leading to an arterial oxygen tension of 900 millimeter of Mercuri column provided by the supersaturated oxygen. For a diffusion, it provides a very high rate of diffusion via the plasma even before the flow is restored downstream, and thus it all reduces the endothelial swelling and allows for the restoration of the microvascular flow. And also this supersaturated oxygen acts on the reducing the infarct size. It increases the oxygen delivery by the blood to the plasma and lead to the decreased microvascular damage, leading to the decreased edema, decreased inflammation and the white cell adhesion, decreased local areas of coagulation, and decreased reactive oxygen species mediated cytokine reactions. Also it increased the regional myocardial blood flow, increased the oxygen delivery to the tissues, improved metabolism by increasing the ATP production and the phosphocreatine, increased endogenous reactive ROS scavengers production, and it ultimately decreases the infarct size and also decreases the apoptosis of the myocardial cells, and thus it lessens the LV dilatation and lessens the LV remodeling. So this is the basic mechanism at the very beginning. In the left side, it deposits the intercoronary indwelling infusion catheter for delivering this supersaturated oxygen in the very beginning trials in the 2009 in the MEO trials directly to the stented region in the proximal of the mid LAD. And the right, the picture, it depicted the method of SS02 delivery that nowadays with a standard diagnostic gel catheter to hyperoxemic blood selectively to the ostium of the left main coronary artery. So this is the basically supersaturated oxygen delivery device. There is a Therox. Blood is withdrawn from a femoral artery sheath and circulated via the roller pump through an extracorporeal oxygenator in a polycarbonate chamber to achieve a PO2 of 762,000. supersaturated oxygen is then delivered into the origin of the left main coronary artery at a flow rate of 100 ml per minute for at least 60 minutes via a 5 French soft tip gel diagnostic catheter. Now, there are some trials like the acute myocardial infarction, the AMIHOT trial. The objective of this trial to determine whether the hyperoxemic reperfusion with the aqueous oxygen improves the recovery of the ventricular function after the PCI, primary PCI. Background was the hyperbaric oxygen reduces the myocardial injury. There are some ideas like that. There are some trials also on that, but though that was not very successful. So these are the patient designs, how they are randomized the patient in the AMIHOT trials in the very beginning. The inclusion criteria was eligible for all patients who have chest pain, 30-minute duration, ST segment elevation 1 millimeter in the 2 contagious leads, or patient with the inferior MI also they are included. And the exclusion criteria was the cardiogenic shock or requirement for any IABP before or during the PCI, coronary CABG within the last 1 month, or a severe pulmonary disease with an PO2 less than 80. There are some angiographical exclusion criteria also, like the ischemic gate flow 3 in the infart vessel at an initial angiography, or a saphenous vein graft lesion, or a significant left main disease, 50% of the diameter stenosis in the infart-related arteries supplying a small amount of the myocardium, and it is the inability to stent the culprit lesion. So, what they found, before the primary efficacy endpoint were the change in the regional wall motion scoring index of the infart zone within the 3 months, or the ST segment curve area, or the final myocardial infarct size. Safety endpoint, incidence of the death, infarction, target vessel revascularization. These are the angiographical and the procedural data between these two groups. And these are the clinical data. Though in this study, they didn't found any significant difference between the death, reinfarction, target vessel revascularization, stroke, or the composite endpoint between the control group and the aqueous oxygen group. But what they found in the subgroup analysis in the anterior wall MI, which is presenting less than 6 hours and going for the primary PCI, they found that the p-value was significant. The aqueous oxygen group in comparison to the control group, the p-value was 0.03. And also, they found in the nuclear infart size determined by the SPECT scan, they found in the subgroup analysis, the anterior MI group, presenting less than 6 hours, they found the p-value is quite significant in the aqueous oxygen group in comparison to the control group. So conclusion was that though it more complete ST segment resolution or reduced infart size, but the therapy was well and self-tolerated. Only thing is that they found that the subgroup analysis, that the anterior wall infart presenting less than 6 hours, it has decreased the infart size significantly. Now comes the second study, there is a AMIHOT 2 study. Here also the exclusion and exclusion are almost the same. The patient design was also same. In the 304 patients with the anterior wall MI, the two primary endpoint, infart size and the safety. So here the results, they have found mainly the result in the AMIHOT 2 trial was that the pooled data, they have found that the difference in the infart size determined by the Tectinium 99mm system B scan, by the SPECT scan, is difference in the SS02 group is 6.5% less than the control group. When they found that the pooled data of both the AMIHOT 1 and the AMIHOT 2 trials, they found that the SS02 therapy group has 6.5% absolute infart size reduction, which is more than the benchmark of more than 5% absolute reduction. And then the other trials are there, the ICHOT study, which is the 2019. It is the latest study, which is basically determined that is the less than the objective performance goal was less than 7%, 7.1% in the this NASH events. So conclusion of this trial was that it may be safely administered of the primary PCI to high-risk patients with a large anterior MI to reduce the infart size and associated with a low rate of adverse event at 30 days. This was the trial. After that, the FDA has approved the SS02 therapy in 2019 for the anterior infart patient with a primary PCI and presenting within less than 6 hours. And that was the one-year outcome of this ICHOT study, which also presented and pointed out the result in a favor of this SS02 therapy in decreasing the infart size. So in the 2019, at the end, the FDA approved the SS02 therapy for the treatment of the anterior MI patients undergoing primary PCI within 6 hours of the symptom onset. That is a basic, not more, beyond 6 hours. So I have to summarize this, that despite successful primary PCI, myocardial salvage, which is frequently suboptimal, resulting in a large infarction with an adverse LV remodeling, leading to the heart failure and subsequent death, SS02 is the first FDA-approved device-based therapy which shown to safely reduce the infarct size in a pivotal randomized control trial. But till date, there are no large randomized trials to prove it, the SS02 therapy in the larger cohort of patients. So it is not adapted in the guidelines in the recent ESC or the SSC AHA guidelines, but it has been approved by the FDA for the recent modality of treatment for this anterior infarct. Thank you, everyone.